Good afternoon. Thank you very much for joining us today. This is different than the way we have typically done our year in review, but honestly, I'm excited about this. This is an opportunity to reach many more people, and although I certainly miss seeing you in person, I'm excited by the opportunities that are presented by this new format, and so I hope that this goes well. I chose the title today to reflect the recognition that there are substantial challenges before us, and we will need to rise to them. Some of the challenges are new, some persistent, and simply being brought out by current events. And some are recalcitrant and have been with us for as long as we've been a country. Though it is an unpleasant analogy, as surgeons, we understand that some of the deepest infections have to be brought to the surface and drained to be healed. And indeed, we will be providing that curative approach in the coming year for sure. I do want to begin this reflection on the last year with a reflection on two outstanding surgeons. This year, we lost two of the greatest surgeons that we have had in our department. Dr. Onye Akwari was the first African-American professor of surgery here at Duke, and indeed was one of the leaders in promoting an opportunity for academic surgery as a career among Black surgeons. He was the founder of the Society of Black Academic Surgeons, was an outstanding academic surgeon himself, studying gut physiology, and a really brilliant teacher, but more importantly, he was a great colleague and a great friend to all around him. I had the pleasure of operating with Dr. Akwari, and we will certainly miss him greatly. We also said farewell to Dr. Walter Wolf, someone else whom I had the pleasure of training with. Dr. Wolf was a superb cardiothoracic surgeon in every way. He was the go-to cardiac surgeon when things were problematic, but he was also a great teacher, and many said he was the moral compass of this department. We will certainly miss these two great men, and I will ask for a brief moment of reflection as we think about their careers. Thank you. So this is a talk with a theme of change and challenge, but it is important to acknowledge that our core mission remains constant. We are here to provide insight regarding the fundamental nature of patients' health and disease. We're here to empower our patients, our trainees, and our colleagues with knowledge, and to provide safe and high quality care based on an advanced understanding of our patients' needs and guided by best practices. These are not things that change. They are at our core. Indeed, we have shown this slide many times. This is our approach. And as you'll notice, our approach begins by listening. And in fact, needs to begin even more importantly by hearing what people have to say. Our approach remains well tested and consistent, but after listening, we need to definitively act and anticipate those actions and measure them and improve them. We have certainly been growing. That has been a constant theme. But to this list of steps toward our approach, this year we must add a new one, and that is to adapt. And I will say that many of our actions this year are adaptations for the good. One of the first major adaptations this year is evident in the emergence of our new organizational model. The Department of Surgery now becoming the section of surgical disciplines comprised of two departments, a department of surgery and a department of head and neck surgery and communication sciences. This year, we are able to give the surgeons in these departments the autonomy that they have earned and deserve, but also preserve the economies of scale and the collaborations that have made our department so rich and successful. This unique adaptation will allow us to keep specialty practices that emerge, giving them their rightful academic standing within the School of Medicine, but again, preserving the important economies of scale required for effective academic resource utilization. Howard Francis, the first chair of this new department, has masterfully developed this group. And here you see the leadership of the new head and neck surgery and communication sciences group. Indeed, the value of this departmental approach has been made immediately apparent with extraordinary impact across all of our missions. Dr. Francis and his group have, in the first year, led to a 23% growth in the regular rank faculty, a 29% growth in clinical revenue. When the first rankings for this new department come out, we anticipate they will already be in the top 20, and they will have another ACGME approved research residency for our trainees to draw from and move forward with. This is outstanding work. There's been 6 new faculty hires into this new department, making clear the commitment to academic development in this new department, with 4 of the 6 new faculty being MD, PhD clinician scientists. In the Department of Surgery, we've also continued to grow and in fact have welcomed 8 new faculty hires this year across multiple different divisions, all of them with academic and clinical expertise that are enriching our mission. Many of our faculty also have been promoted in these departments. Together, we've celebrated the advancement of many stellar faculty, including Chuck Girardo, who became the first and will certainly not be the last emergency medicine physician to reach the pinnacle academic rank of full professor. Congratulations, Dr. Girardo. Our clinical mission is, as always, our central and most visible mission, so I'd like to have a few moments to speak to that. Not surprisingly, the recent pandemic significantly limited our operative volume. But if you look in a little more granular function, indeed, we were on another record pace before the pandemic required that we slowed down to make capacity for the wave of patients with COVID-19. And as you can see, we are quickly making our way back to full clinical capability. I will point out that we are not ramping up or doing volume just to do volume, but we're not trying to return to normal. Rather, we are adapting to a new coexistence with a community that will be battling the coronavirus for the foreseeable future. And in fact, that theme of adaptation, that theme of working in a coexistent manner is an important theme in many different contexts this year. If we look at the fiscal impact of this slowdown, you'll see that with our slowdown in volume, we have certainly seen a significant fiscal reduction. This slide actually shows hospital charges and physician charges, both for our health system, but also for our community of academic health systems around the country, our peer institutions. And you can see that our economic impact is matched by almost every other peer institution around the country. I think that we will certainly feel this impact, but we entered the pandemic as strong fiscally as we've ever been as a department, and will emerge from this equally strong. Critical in this will be continuing an intense focus on quality. Over the past 5 years, we have put in place a nation-leading suite of quality assessment resources to remain very introspective about our care and, that we deliver to patients. We are very fortunate to have these high fidelity data streams to give us situational awareness. And many thanks to Chris Manti and his team for building this important series of tools to continue to allow us to deliver outstanding care. No matter what the volume of care we deliver, it always has to be high quality care. Similarly, we are fortunate to be in a health system that has taken quality seriously and gives us grade A facilities at every one of our hospitals. This has come from a lot of work from our hospital presidents and from our new Chief Quality Officer, Richard Shannon, who all have been great partners in helping us get the resources we need to stay on the leading edge of healthcare. Not surprisingly, with all this attention to quality, the mortality of patients that we treat and those receiving care in surgery at Duke is now lower than it has been. And in fact, it is significantly lower than would be expected given the complexity of patients that we see. This focus on quality is saving lives every single day. Our new development this year that is continuing to help us improve quality has been the PASS Clinic. And this is a nice demonstration of our section's collaboration with the Department of Anesthesiology. It is clear that one of the best ways to get high quality outcomes is to optimize the health of patients approaching surgical procedures. Many thanks to Saul Aronson for his conceptual development of this vital perioperative optimization clinic, and to Gina Blitz for her superb operational management of what will certainly be increasingly important as we adapt our care to the challenges before us. A great example is in reducing the need for blood transfusion, an increasingly important issue given the current blood shortages that are facing us now. I'm also gratified that we have been able to co-publish with the Department of Anesthesiology this experience to help drive the policy discussions around our improved perioperative management nationwide so that we can continue to lead the dialogue on how best to care for patients undergoing surgery. This is especially true for our elderly populations who have been particularly vulnerable during this year. It has been impressive to watch Dr. Sanjay Lagu and her POSH team develop a robust process to help optimize the health of elderly patients who are approaching surgery, and also turn this into generalizable processes that are published in high-impact journals like this publication in JAMA Surgery this year. Again, turning process toward policy and leading the nation in how to provide best practices in care for vulnerable patients. Indeed, our capacity to examine data and to turn it into actionable clinical improvements has never been more facile, and it's been driven in large part by the LTA, or the Laboratory for Transformative Administration, a surgery-specific core for implementing learning health unit practices into our day-to-day operations. Many thanks to Wendy Webster, Lisa Pickett, Dan Buckland, and John Rollman, and the many residents from multiple departments who have engaged in this really transformative work. We have 83,000 plus patients experience to draw from every year. And indeed, we can learn through this living data set how best to provide care more efficiently and more safely. Another key contribution this year has been a collaboration with Suresh Balu and the team from the Duke Institute for Health Innovation, or DHI. This remarkable group has given us what they now call the DHI Data Pipeline, a tool that gives us near real-time access to all data from all patients and all procedures. This is an access to data that was unimaginable just a few years ago. Indeed, we now have on tap over 4 terabytes of data, growing every single day to fuel innovation of our faculty, our staff, and our trainees, and we have never been in a better position to make data-driven adaptations to our care. As a simple example, we've been able to look at all of the scheduled cases, not only for how they performed, but also how they were predicted to perform based on their scheduling, and to look at real metrics to find systematic opportunities for more accurate posting times. This has helped us more accurately anticipate the resource needs for cases as we assess the schedule day to day and relate to ever-changing capacity demands that come to us posed by the pandemic. The last year, we have also rolled out a new machine learning platform to help surgeons find time and room to do the cases for their patients. And in just 1 year, we have improved operational efficiency by 3% and moved over 2 million minutes. That's about 4 years worth of minutes of operating room time into a domain where it can be shared between surgical teams. This has allowed us to do over 8 cases every single day in regular business hours, reducing the stress on our teams caused by running rooms late and forcing overtime. This improves care not just for our patients, but for each other, and helps us develop resilience in our teamwork. This will continue to be a great tool for our adaptive work in the coming year. And we've used that extra OR time to do really remarkable things. Just to mention a few, this past year we did our 2,000th lung transplant. Our lung transplant team has long been one of the most outstanding lung transplant teams in the world. And indeed, this year they are on pace to do more lung transplants than ever before. Not only great numbers of lung transplants, but with highest quality in some of the most difficult patients. Doctors Zani and Litsky performed the first robotic-assisted hepatic artery infusion in North Carolina this year, bringing an entirely new approach to care for patients with advanced hepatic and metastatic cancer to patients in the Mid-Atlantic region, something that wasn't available anywhere but a few places around the world is now being driven in the Duke Cancer Institute by this type of innovation. The HOPE Act, which allows HIV-positive living donors to donate to individuals, is a new regulatory act that came about this year, and we, in our transplant program, were able to do the first HIV-positive living kidney donor in our region. Again, opening up the opportunities for curative care to a whole new group of individuals that had been systematically excluded from living donation. And in fact, in what I continue to think is incredibly remarkable, this year, Drs. Jacob Schroeder, Ben Briner, and Carmela Milano did the very first DCD heart transplant. They also did the first heart kidney transplant from a DCD donor. To be clear, a DCD donor is a donor who has died and whose heart has stopped. And in this remarkable procedure, this heart was removed, reanimated, and then brought to the chest of somebody in heart failure and cured them of their heart failure. This is truly remarkable cutting-edge therapy. I know that our patients are grateful, but one of the best expressions of gratitude that I've ever seen is one of our hand transplant patients writing the thank you note with his new hand. If that does not inspire you as to what we can do when we work together as a team, I'm not sure what will. I'd like to speak briefly about our research mission, because of course, on top of extraordinary clinical practice, we also want to develop the therapies for patients to come in the future. And indeed, surgeons and research are becoming a dying breed. This publication from a couple years ago in Nature made it clear that surgeons must start doing more basic science research. And in fact, it is our job to allow the environment for surgeons to be able to grow in this research venue. I think that we're doing a superb job in this regard. Just about 18 months ago, you were introduced to a group of 7 junior faculty members who were focusing on developing careers as surgeon scientists in the most rigorous sense of the word. And as you are all aware, this is an exceptionally competitive arena with a less than 10% success rate for young surgeons in achieving NIH funding. As an indication of the talent of this group, but also the robust support systems that we've created to build clinician science development, already 5 of these individuals are now NIH funded, with the other 2 poised with applications on the way. This type of success rate is remarkable for what it says about these dedicated faculty, but it's also remarkable for what it says about the collective dedication of our department to this important mission. Congratulations to these superb young faculty members. Indeed, our entire department continues to grow in its success in the academic realm. This is indicative of current growth with extraordinary growth in our research funding. It also is indicated by our diversification. We are well diversified in our research portfolio with NIH funding, other federal funding, Department of Defense funding, foundation funding, and industry funding, such that our resilience to significant changes in any of these domains is mitigated by a portfolio that is not dependent on a single type of research funding. The Division of Surgical Sciences is also an extraordinary resource. It is, in fact, unique, I would say, to our section of surgical sciences. This is not only an internationally respected group of scientists, but it is also a group that has exceptionally developed collaboration and a transitionally focused agenda to partner with clinicians and bring rigorous science to the bedside and receive clinical insights at the bench. Indeed, I would say that the Division of Surgical Sciences has had one of its most successful years ever. It's also worth mentioning this year that we saw our first R01 and first NIH-U grant in our Division of Emergency Medicine, a group that we hope to move to department status within the section model. And this type of high-level, rigorous NIH funding is an extraordinary example of the type of robust academic environment that's being developed in the superb clinical division of emergency medicine. And rapid growth in the Department of Head and Neck Surgery and Communication Sciences is also seen, including new expertise in epidemiology and population health with the new hire of Nosa Osazua-Peter. And indeed, you can see many robust NIH grants that have already come in just in the first year of this new department's existence. I would say, judging from the over 300 projects fostered by our pre-award team and our grants development program, I think the future for research here looks bright. Of course, grants are immaterial if we don't convert them into generalizable insights that can be distributed. And this year we had a record number of publications in the peer-reviewed literature with almost 800 new papers emerging from our section just within the last 12 months. Science in our section is not partitioned activity that's relegated to just a few members of the section or a few areas of the department. Rather, in the past few years, we have initiated an audacious project that enables the entire department in capturing the biology of an episode of surgery. Through the 1,000 Patient Project, a large-scale clinical and assay-based data acquisition project, we have set out to truly define the biology of human injury, acquire a deep definition of what patients are at baseline, look at a stereotyped response of stress, and define recovery and resilience to patients undergoing that stress. We have focused on dynamic episodes of well-characterized injury, and in the past year, we have made substantial headway in this very novel project. We are looking currently at 12 particular procedures, bringing both clinical data and biological samples to the laboratory to be converted into a comprehensive data catalog. And just in the past few months, we have started to see extraordinarily rich data emerge from this project. Shown here, just a few examples of the proteomic protein assays that have come out, the transcriptomics analysis, the microbiomic analysis, and the flow immunomics that we're now being able to look at to see what it means to be a patient undergoing surgery at the most fundamental level. This will be an extraordinarily rich data set for our faculty to draw from for preliminary data and for us to develop new insights in how to deliver better care. We've continued extraordinary activities with partners with the Department of Defense through the Surgical Critical Care Initiative program, taking clinical data and assay-based data and pulling it together to develop clinical decision support tools. And indeed, in the last year and a half, we have deployed 4 new clinical decision support tools out to the front lines to warfighters to help physicians caring for them in the front lines care for them in the best, most efficient manner. Indeed, our academic reach is global, and our global surgery group has continued to grow and achieve accolades such as this Global Health Endeavors Department Award by the Global Emergency Medicine Academy. Congratulations on having this broad global reach. I think that it's important to recognize that our research is extraordinarily relevant to the times as well. As our entire country will be facing economic hardship, we already have a robust process led by Rachel Grennip in studying the financial hardships that patients are exposed to when they have to undergo medical care. This is not something that we spun up just because there's a financial crisis. This is something that we have been engaged in and leading nationally for years, recognizing this out on the leading edge. But of course, it will be more important than ever now. Similarly, we have faculty that have been having important dialogue on recognizing racial inequities, such as this high impact paper by Lola Fyanju published in JAMA this year, giving insights on the problems that are hiding in plain sight in modern medicine. Again, this is not something that we've done just because now it seems imperative to do it. This is research that we have invested in and have been doing now because we have long known that these types of inequities are influencing our patients. The educational mission has continued to grow and improve as well. Indeed, as we look at Duke surgery as it's rated by U.S. News and World Report, we are, perennially in the top 5. But we are continuing to drive the pipeline of great academic surgeon scientists. In achieving 2 T32 grants for training, we've been able to train 5 individuals in the past year with dedicated time for scientific study, time that's completely protected from clinical activity. And this group is certainly going to become the next group of junior faculty that will be achieving the way our current junior faculty are. And I think it's important to congratulate Muath Bashawi for successfully defending his PhD in biomedical engineering just this past month. It is extraordinary that we bring trainees here that are already facing 8 or more years of clinical training and want to then go deeper into the science to develop the type of robust understanding of their craft to lead nationally in the future. We have continued to help nationally in developing better curricula to train our medical students. And in fact, the Association for Surgical Education Curriculum Committee, which has been co-chaired by our Vice Chair for Education, Dr. Ranjan Sudan, has brought a beta test to the new surgical education curriculum to our medical students. And indeed, we've been piloting this for the past year. Our experiences are going to change the way surgery is taught in every department of surgery around the country based on this collaboration. The STAR course is also an extraordinary example of how we have really focused on training and how that training mission goes deep into our trainees. The STAR course is a course that our residents have put together for our medical students that are interested in going into surgical discipline. And each year, the enrollment in this class has grown. It doubled last year, and in fact, it is now oversubscribed every year. This is a unique opportunity, not only for our medical students who are interested in surgery to learn new skills, but for our residents to learn the skill of teaching and for us to grow in our ability to help one another as we are growing in our acquisition of surgical abilities. It is impossible to develop rich educational environments without the help of philanthropic donors. And we've been successful in increasing the number of endowed accounts and the size of the surgery endowment, but we certainly remain in need, particularly in the coming years. For philanthropic support to keep the training mission at the pinnacle of academic surgical training, we will need partnership with our alumni, with our patients, with industry, and with others that have a shared interest in improving the quality of surgical care delivery. And indeed, that sort of partnership brings me to a discussion of citizenship. We are reaching out to the community to be good citizens in our local community. We are not simply talking about diversity, but we are reaching into the most vulnerable pockets of Durham to help elevate, for example, high-risk children through the ASSET program, which was initially founded by the late, great Joe Moylan, the former chief of trauma surgery, and his wife, Ann Carroll, who we sadly lost this year. More than 200 young boys have been able to participate in the ASSET program. They've been able to come to do anatomy workshops, work in the fresh tissue lab, work in the SEAL simulation lab, and even have been able to learn developing virtual COVID-19 models to be created to teach these young boys about the importance of understanding the pandemic situation that we're in. We are reaching into the community to try to combat disparity of care. In fact, disparity of care is deeply seen in breast cancer, and this project that has been put forward by our breast cancer group has sponsored numerous community events to improve breast cancer awareness, elevate breast cancer screening, and improve breast cancer treatment for all patients in our community. And as much as we have reached out into our community has reached back in so many ways, including, for example, the Smile Stand. This was the first annual event that was developed by a mother of a successful patient dedicated toward improving the cleft and craniofacial surgery team and improve the ability of children to receive this vital care that they so much deserve. Interestingly, the owners of a pub called Mojo's on the harbor, Harbor John and Andrea Petria donated dollar bills that had decorated their restaurant for decades to help improve pancreatic cancer research. This donation honored a dear friend of theirs who actually placed the first dollar as their first customer back in 2011 and passed in 2012. And they made it their goal to literally wallpaper their establishment with dollars that were destined for philanthropic support. We have improved our philanthropic capacity here and had several promising major gifts going forward, but we will need to improve in this if we are going to continue to rise to the challenges that are before us. Now, as alluded to numerous times today, we can't end this year in review without making some specific mention of our crisis response. We have responded and are responding to many crises now. I think it's important to point out that we have been preparing for crisis for many years. Indeed, our broad engagement in the One Duke Peri-Op Initiative, which is a comprehensive program involving everyone in the perioperative space, in our section and in every department of surgery, through the nursing group, the individuals who work in sterile processing, our administrative staff, everyone that touches a surgical patient has been involved in this. We have been working to develop our collaborative skills and foster our competence in showing universal respect, teamwork, and ownership. This has been embraced for a general purpose, but it has been very specifically responsible for much of our success during the COVID pandemic, because these skills are what have really gotten us to work well together under the duress that we have faced in the past several months. Indeed, this One Duke Peri-Op Initiative has given rise to a culture of clinical leadership and a culture of clinical discussion through huddles and collab labs so that people can listen, formulate solutions at the ground level, and advance them without unnecessary administrative burden. And it's this type of work that has allowed us to step into the front lines of the crisis of the coronavirus pandemic and care for patients as they have come to us. It is the type of collaborative environment that has allowed us to quickly adjudicate cases and establish really on a day-to-day basis what cases we can do and what cases we can't do based on the fluctuating volume and fluctuating need for capacity that our health system and particularly our intensive care units have made. This type of collaborative environment is what's allowed us to take the most robust research program in all of surgery and bring it to a screeching halt in just a week, and again, to bring it back to a more adaptive model to be able to coexist with our new environment and still be productive in, again, just a few weeks. It's this type of collaboration and communication that's allowed our residents to work in platoons and for us to continue to communicate and share clinical experiences in real time. And that has certainly allowed us to provide stronger support for each member of the team. It's allowed us to take our administrative support, like our Surgery Access Center, and work with them while they support us from home to allow us to care for our patients. Indeed, they've been able to convert in-clinic visits to telehealth visits in a way that is quite unprecedented. Indeed, telehealth visits were almost unheard of just a few months ago, and now it is the new way we do business. We are not returning to normal. We are not going back to the past. We are adapting to coexist with a new challenge. You can see here that as we have started to emerge, that nearly a third of our new visits are now telephone visits or video visits, and that has allowed us to get patients the care they need without putting them at risk or threatening the type of capacity constraints that we have. We are now scheduling cases so that surgeons can prioritize their cases so that if, in fact, we have to go back into a retraction mode, we won't have to do that with the same sort of challenging dialogue that we had at the beginning of this crisis, that this will be hard banked into our scheduling process. And indeed, this type of organization has allowed us to move into partnership with, for example, the engineering school, to have our residents find problems like the need for ventilator splitters or the need for ways of moving patients with coronavirus infection through the hospital safely, and to bring this from a concept to a FDA approvable product in just a month and a half. This is the type of example that you could only find in a place where research and education and clinical care are so tightly woven in an environment of cooperative spirit. It's important to know that our researchers, particularly in the section of surgical sciences and in the division of surgical sciences, are leading the nation in developing a vaccine for the coronavirus. Doctors Guido Ferrari, David Montefiore, and Georgia Tomaris are some of the nation's leading researchers in trying to find a permanent solution for this global scourge. Indeed, there are many, many grants that have already been enacted just in the last 2 months within our department to help us find a new way to coexist with this viral pandemic. 2 really interesting trials that are now interventional trials include the ORCID trial, which is looking at novel therapies for treatment of coronavirus, and a mesenchymal stem cell trial that's being driven by our cardiac surgery group. Both of these are now actively enrolling patients and leading a national multi-center trial to directly treat patients with novel therapies. Of course, one can think about novel therapies and look to the future, but we don't have to look to the future or look to other centers to see miracles that are occurring every single day. This is one of the most impressive ones that I have come across anywhere. A mother who, after delivering her child, developed coronavirus and was stricken with severe pneumonia, requiring that she go on extracorporeal membrane oxygenation support. Indeed, she was ventilated and on ECMO for 2 months, but was able to be extubated and leave the hospital to see her child for the first time through the direct innovation and hard work of individuals in our division, in our department, in our section, and our collaborations with the many departments that have brought this type of multidisciplinary, truly miraculous care to the routine in this pandemic. As we examine our now very familiar vision statement, United for All Patients, we have started expanding that to just United for All. Indeed, every single week, we have been able to push out messages of gratitude to specific units from specific units across the section and help provide resources every single week to help people be resilient in this space. We are establishing a much better dialogue and a much better means of communication with one another. But of course, as we listen to one another, as we communicate with one another, our desire to foster an inclusive environment begins as we began this lecture with the ability to listen to everyone and to hear what they have to say, even when that is uncomfortable. Our D&I committee started open dialogues long before the current public social unrest was evident. Years back, they started having dialogues in unconscious bias. And now that we are seeing this, these types of dialogues are more important than ever. The basic beginnings of how we have tried to approach everything, again, is to listen. And what we hear is unfortunately not surprising and not good. It speaks to the pervasiveness of inequity in our environment. This speaks to the deep-seated and protracted nature of our current social problems. This is not a new problem, although many people are hearing it new for the first time. That's because they are now listening for the first time. And I feel that our department needs to listen for many of us for the first time. This speaks to problems that are old, for wounds that have not been effectively dealt with throughout history. Again, history has often tried to apply a bandage to cover this abscess. Even in an environment that seems to be successful and progressive, like the environment that we have built here in Duke Surgery, we are not doing as well as we should. In the realm of cultural change, we have not been effective, and it is a detriment to us all. We have certainly had displays of unity, like this moment where Duke Health honored the remembrance of George Floyd by standing in the courtyard for 8 minutes and 46 seconds just this past June. In the recent march that brought well over 1,000 people in unity to express our disdain for our current predicament. But this is not what we need to advance. This will not get us through this persistent, recalcitrant social crisis. We need a reality check. Physicians, surgeons, and scientists are fundamentally based in reality. We don't imagine disease, we hold disease. We do not imagine solutions or mechanisms to problems, we dig deep to find the reality. The problems we face are complex, but we have to rise to them. And we have to be focused on the reality that we have not done the job we need to do. And going forward, we must. The challenges we face are not limited to those in our ORs. They're not limited to our clinics or to our labs or to our break rooms, but to be sure they reach into these environments. They impede our ability to deliver the care to our patients, the care our patients deserve, and the respect our patients deserve. I don't have simple answers, though I will say that the fundamental principles of respect, teamwork, and ownership are certainly a part of the solution. Fundamentally, respect for all people and the ability to see the world through their eyes, not through our own eyes, resisting the human tendency to be self-centered and approaching the world through the altruistic principles that we hold dear as clinicians and scientists. This altruism is key. This reflection is key. This ability to see ourselves as other people see us and vice versa is key. I'll also say that we need to listen to one another, and in particular, listen to our trainees much more earnestly than we have. We may be able to teach them to do a procedure or to understand an experiment, but our trainees will teach us how the world needs to be. It's how their world needs to be. And certainly, speaking to the senior faculty, we need to hear our students, our residents, our staff. We need to hear everybody, not just listen, but to truly hear them. This is their world.
here in finance,
in data management,
as advanced practice providers,
in communications,
in GME programs,
in pediatric general surgery.
we aim to be
united.
united
for all patients,
in divisional administration,
in population health,
in research,
in plastic surgery,
In human resources,
in head and neck surgery,
in abdominal transplant,
in vascular and endovascular surgery.
we aspire to be.
we aspire to be.
we aspire to be.
united,
United.
united,
united,
For all patients.
in trauma,
in the call center, in the SEAL lab,
in hand surgery,
we commit to being
united,
for all patients.
In CFAR,
in metabolic and weight loss surgery,
in soccer,
we desire to be
united for all patients.
In SCORES,
in our clinics,
as nurse practitioners,
In education,
in surgical sciences,
in emergency medicine,
we hope to be
united,
united,
for all patients.
In administration,
in research development,
In CT surgery,
in diversity and inclusion,
in IT,
in surgical oncology,
as a physician assistant,
in research administration.
in geriatric surgery,
we strive to be
we strive to be
we strive to be
united.
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 for all patients.
Thank you very much for being here this afternoon. I am happy to take questions from the audience and hope to be able to answer those questions, if not within the time confines that we have now, through direct communication. And you're certainly welcome to email me those questions. We'll try to collect them and do what we can now. The first question that I see is, what are our plans to maintain financial security with the loss of revenue that is created by COVID-19? Obviously, we're all concerned about this. As I said earlier, we entered this crisis in an exceptionally good financial position, but there is no doubt that we will have financial challenges going forward, not just within our section, but across the entire institution. And in fact, our patients will have that financial challenge. We are looking to keep expenses in check for sure. We're not traveling anymore, as you all know. We're closely monitoring and supporting the development of professional revenue. We're trying to improve our ability to collect the receipts that we have, and we're trying to deliver the care that we need to deliver. But this is something that we're going to have to look at every single week. It's going to be a fluid situation. I will say, though, that while our plan for this may change every single day, we will be focusing on this every single day to make sure that our section of surgical disciplines is as secure as it possibly can be. Another question is, what challenges exist for virtual recruitment of trainees? How will they be addressed? I think that this is actually a great opportunity. The old way of interviewing trainees was very clumsy and very expensive, and it excluded individuals that had a difficult time traveling. And it also required that we all try to be in the same room at the same time. A new opportunity is before us. We can reach broader for our trainee applicants. We can allow them to see more about our institution. We can provide content for them that is not something they have to sit in a room to see, but they can watch at their own leisure. The length of interviews can go longer and can go broader, and we can make sure that they interview with the people that they want to interview with. I think that our approach to interviewing trainees will probably be the best, most comprehensive approach that we've ever had, just by having this opportunity to change. I have one more question here, and I know time is late. We will, let's see, what are the plans to recruit and retain a more diverse faculty? This is something that we have worked on diligently for the past several years, but we have not made the headway that we want to make. The most important way to recruit a diverse faculty is to respect diversity of opinion and to make people feel respected, not only when they're being recruited, but when they are here. We have to improve our ability to hear things that are foreign to us and to balance our response to that to be more acceptant, to be more tolerant and more focused on a broad approach toward a collective opinion. Our Diversity and Inclusion Committee has certainly been helping develop the dialogue that we need in this space, but we are reaching out to our medical students, our medical student organizations, our residents, to understand what will help us recruit a more diverse community. We're also making sure that when we are intolerant, that we call that for what it is and walk it back quickly so that we don't display the types of behaviors that have prevented us from being as welcoming an environment as we can. I will certainly say that my responsibility for building the best section of surgical disciplines and the best departments of surgery is dependent on developing a diverse faculty, on respecting diversity of opinion, and on bringing in people that provide a wide range of views scientifically, educationally, and clinically, while still maintaining the high standards of performance that we expect. I will close now by again thanking you all for listening and thanking the many people that helped put this presentation together. I hope that you share this presentation with individuals that were not able to hear it, and I am always available to answer questions and to respond to your concerns. Thank you very much.